All right. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. This is the second meeting for the Advanced Payment Model Learning Collaborative. A couple reminders. Please join the audio version of the webinar with your telephone so we can participate fully, and mute your computer speakers when you join, as there will be a feedback loop from your phone's microphone. All phones are muted by default when you join, so *2 will unmute your line to ask questions or participate in the discussion. A reminder that, excuse me? A reminder to all Flex coordinators, if you have other people in your office who would like to participate and sit in on the webinars and learn from this learning collaborative, that is not only allowed, it's encouraged. We definitely don't want one person in the office to be siloed alone with this information. We feel it's beneficial and relevant for everyone in your Flex office to benefit from this, as well as the activities from your Flex program will be much stronger and better as you have more people participating throughout your office. I'll remind everyone that we have an external SharePoint, an external website where we post the slides from the presentations as well as the webinar recording should you not be able to participate live. And there's also a discussion board or forum there, which we hope to utilize. We had a couple questions in there about the homework assignment, and I did my best to try to answer those, but if we didn't get those answered, that's why we come back to the meeting every week. So without any further updates, I will let Shannon get started.
Thank you, Caleb. I appreciate that. And hello and good afternoon, everyone. So happy that you have joined me again today. And I'm sorry, I see Tracy's question. I'll answer that in 1 second, Tracy. And I'm excited that everyone is here to join me again from last week. The interesting thing that we had last week, we'll try to recap and hopefully answer questions from last week, and then move on for the program today. So thank you again to the National Rural Health Resource Center for organizing this program and helping us to move forward in healthcare transformation. So last week, it's moving forward without me doing that, Caleb. Is there something you can help me with? Maybe there's a delay. I think it's progress. It's going forward without. Okay, I think I have it. Sorry about that, guys. So in the context for this presentation today, I wanted to let you know that I want to build on the first webinar and carry that through all of the 6 webinars so that you have a good understanding of Medicare's program on transformation, the goals and intention, and the mechanics of the programs. We touched at that at a high level last week. And this week, I really want to put that into a little bit of application. And so considering what the first step would be, and that will be talking about population health and how that helps you be successful in transformation, and also how that relates to cost, quality, and total patient spend. And towards the end, I also want to just touch on what the myths might be about shifting cost, quality, and total patient spend as it relates to critical access hospitals. So the last webinar series was regarding understanding payment and delivery reform. This week, of course, we're talking about population health. Then we'll follow with practice transformation and drill down into hierarchical condition category coding. Try to say that 3 times. And my screen just went away, Caleb. I'm not sure what's happening today.
I'm not sure either. We'll get it get it squared away here.
Okay, thanks.
No problem.
While he's doing that, I'll continue to talk with you guys. Apologies for that. So we'll talk about the myths. And while we're pausing here, Tracy, remind me your question. I think it was about if you did not, what was it, if you did not understand the question of what you're supposed to ask when you talk with people in transformation?
Yeah, so I was, can you hear me?
Yes.
Good, okay. So I was just wanting some clarification on who you had in mind that we should be talking to at these hospitals and what kinds of questions I could let them know that I would be likely to ask them, just so that I'm not, potentially asking the wrong person, or, not able to let them know like what they're signing up for.
Sure. So basically we'll be just asking questions in regard to whether or not they're participating in value-based payments. It might be a practice manager. So particularly, the behavioral health clinics, that you could ask them, the practice manager, do you do primary care or outpatient value-based services? Do you have any kind of contracts with commercial payers that are in value-based services? And I think that question will get you to the point of what you need to know, which is they may ask you more detail, and if they do, then they probably are, or at least interested. And if they say, what is that, then we know that's probably not the client that we were looking for to have a conversation with. Does that help?
Yeah, I think it does, yeah.
Okay. And I'll have another suggestion in just a few minutes, so I'll let you know what the idea is around that in 1 second, and maybe that'll give you some clarification. Thank you. Again, I thought that maybe answered when I got the post to Caleb, so I apologize for that. I always feel like you could email me and ask a question. I have no problem with you doing that, and my information is included at the end of the PowerPoint presentation. As I was saying, that we will go through hierarchical condition category coding and try to say that 3 times, which is not easy. And then we'll try to dig into the return on investment for value-based care. And I'll wrap it up of the entire series with the big picture results matter, and that's how it applies beyond Medicare and what we can do about that. So does anyone have any thoughts about or questions about last week's webinar? I'll pause now, and if there's something that wasn't clear in regard to the presentation, or if you wanted to ask more, I'm happy to pause now to make sure, because we're going to move forward in the idea. And I see someone's typing, so I'll wait just a minute. In the meanwhile, while this question is being posted, also think about if anyone wants to share about how your calls went with your hospitals, and if you did in fact find 5. So, okay, Jill, thank you. So no questions at this point. I'm happy to hear that, but please feel free in the process of this webinar that if you have questions or clarifications because you weren't on last week, please stop me and I'll try to help answer and get you on the same page. So can everyone sort of type an answer to say, yes, they found their 5? And I know some of you are multiple people from one state, so as a collective, did you find 5? And if you say no, could you also say that you found none, or you just stopped after inquiring for a while? Like maybe one of you said no, if you can tell me what happened when you asked. And we're getting some good questions. Okay, we've got multiple typing. I have some, and some that are waiting for clarification, so they'll start today. That's great. Okay, and I'll keep listening to that. So what I want you to do is, really the intention of this webinar series is to get you comfortable while you're in this series being able to communicate with your practices, with your critical access hospitals and rural health clinics, specifically about the topic of transformation. And so one of my first thoughts was if you could just do a test of several to say, are you in value-based, or are you doing something that's with alternative payment models, which is a type of value-based. And that's all I wanted to know was, did you find some in the first one? Just give you a chance to reach out and start talking to somebody, and then find out, do they have value-based payments? And if the case was yes, then ask if they would mind that you could follow up with some questions to understand more. And the intention is to build dialogue, so you get a sense of who in your practice or in the hospital that you might talk to. What might happen is that you would call a quality person, and it would actually be the practice manager, or vice versa. You might end up talking to the CFO, or who does the payer contractings, and find out that that's where it goes. So I didn't want to really give you a preconceived idea. I wanted you to do some investigating on your own. It sounds like some did find some, and they wanted to know what type of commitment. So what I was going to ask you to do after you found some, I'll share with you shortly on this next slide, or actually towards the end of the program. So I'm happy to see that there were some that were able to participate, and there were several that did not participate in reaching out, and looks like there's new folks that are joining us today. So welcome, and be sure to go back and listen to the webinar for the first one so that you can get caught up, and then if you do have questions, as always, feel free to reach out to me. So it seems like we had contact and that we're not sure who to talk to. And what is interesting, and I'll share with you, is that it's not ever clear and consistent on who you talk to and who's really participating in value-based payments and transformation. It's also not widespread, generally speaking, so it looks like we're getting quite a few of those with that type of response as well. They do not have to be caused. Generally, we're going to look towards the practice rural health clinic and practice manager in the rural health clinic. So it's primary care driven, generally speaking. So that was one question. Do these hospitals have to be caused? All right. So what we discussed last week was really talking about the pillars of transformation as it applies to Medicare. And we also talked about cost and quality and what Medicare is trying to achieve, what their goals and intentions are. And so I'm going to give you some application to that, and please feel free, even if you weren't on before, to ask questions as we go through this. So back at the beginning, Medicare had what was called the triple aim, and it's still in place. They don't refer to it as much, but the triple aim was better health, better care, and lower costs. And that's what they are trying to accomplish. What I would tell you is that this is always in the lens of total spend on the Medicare population. And so to translate those words, better health, better care, and lower costs, it doesn't mean that you're providing bad care, and it doesn't mean that they want to deny your current reimbursements. What it means is lower costs in the context of the total spend. And I'll reiterate for those of you that were not on last week, total spend is what Medicare spends on an average person in a specific pool that's in a plan. So a Medicare beneficiary in a certain geographic region may actually, on average, cost anywhere from $7,000 to $13,000 a year. That's the total average spend. It's not the cost that hospital bills to the plan, but it's what the total average spend on the patient is. And this is how they determine what they calculate for their own risk. So lower cost is really about lowering the total spend. Remember last week we talked about bending the curve of the escalation of costs to Medicare. And the underlying belief of this is that there is a lot to be done in prevention and wellness, a way in which providers can engage with their patients earlier for early detection and then management of the disease state. So better care means having processes in place to capture those problems, to have good evidence-based programs and document those so that that can be demonstrated to who the payer is, this time Medicare, that you are providing quote-unquote better care. And better health really relates to the outcome of the patient. For instance, rather than having the patient going transactional I don't mean the patient going on transactional, in fee-for-service and transactional type of care that we're living in today, the patient gets sick, they go to the practice treats them, they file the bill, the patient goes home, and they wait until the patient comes back again. It's a transaction. Medicare's willing to sort of turn that on its side and pay you in a more holistic way, in a total spend and patient-centered care, with a better chance of managing those patients earlier so that it doesn't end up with the most expensive way of care, which is either in preventable emergencies or preventable admissions. So that's the context of better health, better care, and lower costs. And that applies to everything as we're talking and moving forward. Yes, first we said, would you also include provider satisfaction? One of the quality measures, so of those three quality measures, better health and better care are actually in the quality sector. And so patient satisfaction and provider satisfaction are both part of the aims. Technically, I'm not sure if we would always call it the quadruple aim, and I have heard some refer to it, so yes, I would agree to that. And so moving forward, how do we actually lower costs, especially in the total spend? You've heard before and probably have seen those not and cause be subject to penalties for having preventable admissions. We all know that probably admissions like pneumonia are not necessarily high in margins of return. So the belief is let's reduce the preventable admissions and help out the patient and also help out the total spend. They also want to see reduction of duplication of services, which I think is a positive outcome for the patient. That is, if a person takes a test while they're in a rural community and then gets referred into an urban center and for whatever reason they duplicate that test. And there's other places that happens as well. They don't want to see duplication of tests when it's not necessary. And then finally, reduce preventable ER visits. If there's a way to help that patient by managing them before they get to the point of needing to go to the emergency room, that reduces costs. How do we increase quality through better health? This is really focused outwardly towards the patient, and one of the first things that you want to do is be able to fill your care gaps and create access for chronically ill at the right time within the practice. I'm so sorry about that. Okay, sorry about that. I'm working off location at a site that has a neighboring sound, so I apologize. And so we also want to encourage the patients to participate in prevention and wellness services. This is an interesting concept, like even care coordination, which isn't so much prevention and wellness, but the culture is that patients always want to see the doctor and not necessarily a medical assistant or a nurse. And so there's a need to do this culture change and being able to have both sides of the party, both providers and patients engaging in prevention and wellness will have a better outcome for health. And then finally, how do we increase quality through better care? This is really about demonstrating the value of the practice and the provider. We have great providers in rural America, but we don't necessarily document them well, and we may or may not have demonstrated processes in place. So we want to make sure that we do provide those prevention and wellness services that help bend the cost curve and do that early detection. We also want to make sure that you utilize new codes and services for care management. there's a whole white space that you've never been paid for, and that's outside the four walls of the practice or the four walls of the hospital, and that is actually where the patient is. There's opportunity and patient engagement in new ways that you haven't been paid for before in the idea of chronic care management and transitions of care. Those two in particular, and then behavioral health care management, are ways to work with the patient outside of the four walls, and utilizing that expands the time of the provider as well as gives that right time availability for the patient. So that gives a better outcome for the patient. The other is that you want to be able to know who the patients are by looking at your roles and being able to determine if they have care gaps, or if you're able to reach out to them. Say you have a diabetic and there needs reminders in place about doing vision checkups or checkups. Those things need to be included in a process so that the patient doesn't fall through the gap. And documentation thoroughly actually makes a big difference in demonstrating, again, the value of what you deliver in your community. One of the things I'll pause here and say that when you're in billing for the all-inclusive rate as your primary revenue source, you historically have not had to bill with more than 4, what's the right word, codes on the actual bill. And what can happen is there may be multiple complications with the patient. And the story is that the payer does not have intelligence moving forward about that every year. So, for instance, and this is sort of a drastic way to demonstrate this to you, but this is the way it's been told across the country, and that is if a person who has had an amputation comes to the hospital over and over again, or the clinic over and over again, and it's not documented at least once every year about that amputation, it's considered in the severity of the disease state that the patient might have in regard to the results of that. And so what that means is that you are not demonstrating with all the time that you're spending with that patient that it equals the resource use for the depth and severity of the disease state. So documentation is critically important in being able to demonstrate your quality, and then also be able to identify where you might not be able to be capturing the problem that you could address and help increase that quality. So this is an interesting slide borrowed again from our friends over at the National Rural Accountable Care Consortium. This was from a rural-based ACO group, and this was demonstrating ACOs. The horizontal lines are ACOs equaling about 40 rural hospitals and practices within this ACO group. And this is their measurements based on their quality measures that they were having to contribute to the ACO. And at this time, this is probably 2015 or it's actually 2015. And so the ACO measures were around 30 measures. They're not as much anymore, but initially they were 30. And 11 came from an annual wellness visit, generally speaking, and about 17 come off of claims. And then the other couple have to be collected in some form and fashion. And what you can see, we don't really have to drill a lot down into the details and the numbers, just looking at the red and green. If you look across the rows, consistently, everybody has red and green. But if we look at the quadrants of at-risk, care coordination, preventative health, and then actual admission rates, we've got admissions down great in rural America. We're doing great in how we're being measured on that. But we are not doing great in documenting on prevention. You can see this red line that's in the middle of the preventative health. And for the most part, the block of preventative health is not done well at all. We've got a couple that are doing really well in one particular area. We're good consistently in some places, but we're consistently not good in other places. And this is how, what I can't say enough about this slide is that it's evident that we are not good demonstrating our value. We haven't had to because we have small numbers. I call it the tyranny of small numbers. So we have low volume, which is very hard to create empirical data to talk about risk. And then our payment methodologies are somewhat skewed because we're of low numbers, that it's not easy to translate to those that are not in the small number world. And so the problem with all commercial payers and now Medicare is that they're viewing us and measuring us based on this type of information. So it's really important that we correct the way we actually document and perhaps treat. This will help us improve some of that by looking at these types of things. It's not quite as much data that's collected now, or it's collected in a different way, but I thought that was telling about rural health. So how do we actually address those codes and correcting them? Because the majority of them were outpatient services and in the clinic. And if we think about what I said, the foundations were back to that better health, better care, and lower cost, starting with the idea of bending the cost curve by prevention and wellness. We really need to think about the opportunity of what a population health program could do. And so we'll talk some about what population health looks like. And I guess the first thing I would say to you is that population health shouldn't just be about the chronically ill. When we first started talking about population health, most people thought that was managing the chronically ill. In truth, it should be managing the entire population. And what that does is actually bring in services that you get paid for all populations that don't take up so much of your time, like an annual wellness visit, that helps build the primary care in a way so that you can actually offer services for real-time needs for chronically ill patients. So, and we'll talk about that at the next week in our practice transformation webinar. So the beginning of the population health program is to use the prevention and wellness codes that are available to you. Annual wellness visit is the primary lead in this. And I would say it's different than the annual physical exam. If generally speaking, what I found was that the physicians want to offer the annual physical exam as opposed to the annual wellness visit, because the doctor does the visit, get to do some diagnosis and treatment in there, and they do a little bit of an annual physical exam. It's a long-standing good relationship between the physician and the patient. The truth is that an annual wellness visit, different from the annual physical exam, is a survey, and it's a survey that helps get in the early detection of the disease states that we have concern about for chronically ill. It also gives us an opportunity to build a relationship for those that don't come in very often. And then there are other things like depression screening, fall risk screening, and even advanced care planning that can all be done under an annual wellness visit. So again, it creates a bit of service that Medicare will pay for without a copay for every Medicare patient. Now there's a variation. There's an initial exam and a subsequent exam. But every patient, every Medicare patient is allowed an annual wellness visit without any copay, and it pays well. So it is suggested that you do an annual wellness visit on every patient. This is hard when the physician sees them all, because you're probably, if I tell you to talk to your practice manager and say this, they're not going to be happy with any of us, because they're booked. You know, they have a full practice and people have to wait to get in. And we'll talk about that, a solution for that in a minute, and that is actually to use nurses or medical assistants for some of these services. You also can use care coordination, and what this does is extend the care management plan that the patient, the nurse, and the doctor actually create together. And this gives the opportunity, number one, a billable code, and number two, a way to give a solution for a person with chronically ill to actually have someone to talk to about their concerns. One of the things I learned on the road in the last 5 years, and struggling with this topic, was that seniors have what is dubbed the golden scroll, and my mother has one. And the golden scroll is all these questions of concerns that they want to ask that are outside of the, presenting problem that they're there for diagnosis and treatment, and a physician just doesn't have time for that. think of that from a senior with a chronically ill condition, and they are even more concerned, and then they tend to be dubbed as non-compliant because they don't know what to do. So care coordination actually helps both cost and both quality. So the other thing is adding on to this, advanced care planning, depression screening, and fall risk screening. This measures and supports the senior population in those things that you could be concerned about. Then, as I said, let's use nurses or a medical assistant, depending on what's happening in your state for these services, and that is acceptable in most states. So I'm going to pause for a minute and remember that row that was the one well-performing ACO. I'll pull it back right here. So row 5 has more greens than reds on it. And I'm going to show you theirs in a different way, just looking at the same set of data, but looking at only one community. And so that row is multiple communities. So this is one community, and this is before they were doing annual wellness visits and what they were doing after annual wellness visits in 1 year, doing prescribed annual wellness visits. They moved 20% of increase of an improvement in doing annual wellness visits, and that meant that they did 25% of their Medicare population in wellness visits. Just 25% with a 20% improvement changed their number from 57 to 77 on the total quality measurement in an ACO. So that's significant, especially for something that you can get paid for doing. And that sort of idea of being able to pull out one idea at a time, figure out what you can do that affects both cost and the two types of qualities in one activity like annual wellness visit, and it makes a significant difference on how you're documenting what you're doing, and then being able to demonstrate to commercial payers and Medicare that you are high quality. You do not have to report. For those of you that were not on the call, we talked last week that if you're exempt, then you don't have to report in the merit-based incentive payment system, or if you're not in an alternative payment model. And either one of those measure you on cost and quality, but they also pay for high quality. You don't receive any increases in payment in Medicare unless you're increasing in quality. So this is a practice that's important regardless of whether you're exempt or not, because you're being measured on this type of information right off of the claim. So this is an example of a nurse-led population health program. This comes from Hattiesburg Clinic in Mississippi, and they have a really great program where they deployed in multiple clinics, a nurse-led program. They were able over time to be able to change the culture of the patients coming to the annual wellness visit separate from when they actually have an exam with the doctor or visit with the doctor. So what you can see here on the data sets, in the first column there was no annual wellness visits done for these patients. And so you can see what scores they had for each of these type of quality measures. And when you had an annual wellness visit done by an MD or a nurse practitioner, you can see that you certainly improved to some degree, but still didn't have high scores. And that probably, again, is because of a time constraint and the need to move on to diagnosis and treatment within that visit. If it's done wholly by a nurse or a medical assistant and then handed off to a doctor or a nurse, you have the ability to increase your scores exponentially. It's remarkable to see what was done between no annual wellness visits, an MD doing it, and a nurse doing it. So that's a suggestion, and we'll talk about that some in workflow in the webinar next week. So the benefits of this for your clinics, your rural clinics, this helps to build primary care capacity. And one way is that in doing population health and this annual wellness visit in particular, you're going to need an extra hour on your schedule for every Medicare beneficiary. an hour for visits for every Medicare beneficiary. Now, if you go tell that to the practice manager, they're probably not going to be really happy because their books are already full. That's with the physician. So how are you able to be able to offer this annual wellness visit, and it comes from the nurse-led program. So imagine you could have, if you had 2,000 Medicare beneficiaries, you could have up to 2,000 new annual wellness visits if you haven't been giving them. And so that would be a whole new revenue. If it's done by the nurse, you could still come into value-based contracting with your physicians, and they would generate RVUs for the physician in doing this, because the nurse would be working under the management of the physician. So having this 1 hour visit, I'll actually do a calculator to show you how to calculate that you could actually pay for a nurse by doing a couple of annual wellness visits a day. The next is the care coordination program, chronic care management. And this allows for right time visits. This is helpful for a couple of things. Number one, if you have patients that are chronically ill, let's say a CHF patient, and they all of a sudden have a rise in their weight and they don't know what to do, and there's not a care plan in place, and they can't get into the clinic, they're going to go straight to the emergency room. That's a preventable admission. If they were in the care management program, they would have had a visit with the doctor and the nurse. They would have developed a care plan, and he would have been able to have a conversation with that care nurse to decide, if this situation happens, then we tell you to do this. If another situation happens, maybe we change your meds, or another situation is we'll work you in today. And so having care management might actually allow there to be a little space open up for the doctor to have real-time visits, while the care management nurse is actually managing some of the patients, where they don't have to come in for stuff that was covered now under a care plan, and being able to be managed by the nurse. So that gives the opportunity to give right-time visits for patients who need them, which is considered a care gap and also low in quality and probably a result of low patient satisfaction. It also increases physician satisfaction to know that they can be helping the patient in a way probably they intended when they went to medical school, and that is to treat the whole patient and the disease rather than transactionally. So last on this bullet, I would like to say that wellness and prevention service helps to build strong relationships with all patients, not just the chronically ill. By doing the population health annual wellness visit, then you're able to offer that to everyone. And by doing the care management, the people who are trying to help those chronically ill, those other people in the household, are so happy to know that there's a care plan in place and some instructions of what to do. So it's a great thing for your physicians and for your patients. The nurse-led program supports the increase in demand. If you use the nurses and the medical assistants to meet the patient needs, and then it also provides additional support to the providers. This allows physicians to get more time to attend acute patient needs, and therefore it actually benefits the patients overall. Both of these things then increase the revenue to support population health staffing. It helps to grow, again, the primary care practice by reminding people to come in for other visits. They might not be, that you think that they're non-compliant, but they really didn't know they had the option or the availability. So again, this helps you to grow your practice in primary care. We can spend more time on that. We'll talk about that next week in the building your practice flow change in order to deliver this. And I'm going to pause for a minute. I can see what the okay. So I see a question. Did the nurse-led program provide CCM telephonic calls and reminders? Yes, it can. Certainly, I won't hold myself out as a person on how to document that, because there is very specific documentation and communication So make sure that you follow those specific rules and work with your MAC on billing that. But yes, calls are appropriate and okay. And then I have a question also. We're still a bit stuck with reaching out for facility contacts and questions. Can you help with this? Here's what would be helpful. What would help us as participants better learn from this activity? Yes, I'm going to provide you some examples shortly. I do have some examples for you shortly, and we could use this clear, concise info to approach and communicate our facilities. It feels like this intro info would help us best explain and share facilities, what we are doing and what we'll be looking for, and what type of info and responses will be expected of them. Everyone wants to be respectful of our facilities' time. So I would be more than happy to help with a script of what you would ask them. And one of the things I do have in this slide deck is a question specific to ask them. And that will come right after this one, so hold tight. So I said earlier it is predicted that population health program would require an extra hour of visit in each patient year, and that is probably one of the most important sustainable things that you can do is to have that many more visits that you're billing the all-inclusive rate in. So if we look at an annual wellness visit as an average billable of $114, and I did 200 days, let's say you did 3 times a day for 200 days, just assuming that's how many that you could have a nurse to do that, times 114, that's $68,400. You would, of course, need to have that many Medicare beneficiaries and a percentage of those in order to be able to hit that number, but that's how you would figure out your calculation. The same goes for the chronic care management nurses. What I can tell you, to get to 150 chronic care management patients is that patients are a bit resistant on having to pay a copay, and there is a copay for this service. I believe it's $8. And the rule of thumb is about 25% of this population that's eligible for chronic care management will accept the copay. The rest don't want to be in it. I think that's a culture thing, and over time that can be changed to a larger number, because if you're managing them on $8, they don't end up in a month, they don't end up in the emergency room or having prescriptions that they have to pay copays and deductibles on. But if you had one chronic care manager paying taking care of 150 patients monthly at $61, that's the complex one, that would give you $77,400 just for doing that one service. And that, again, does quite a bit. And then a question here is, are blood draws labs included in the hour-long visit? No, they're not. The hour-long visit is it's just on average. I mean, you might be able to be a lot more efficient in your time and getting through the full annual wellness visit. However, depending on the population and the questions they ask and what you're trying to get done, it could be difficult. So we measure generally about 45 minutes. So I say an hour to get them in and room them and so forth. Okay, and I see in one state it says the copay is around $20 a month, probably for the $61 one. Would you say that's also for the $43 one? Maybe you can answer that, because it was originally $8. It could have evolved, so I apologize for that. The annual wellness visit may seem like a long one, but we go through, if you do it correctly, and this is answering a question that seems like a long appointment. There are questions about doing a fall, a mini COG. You do advanced care planning, so end-of-life planning, which takes some time. And then you go through smoking cessation, all of the questions that you ask for wellness and prevention, and then you need to document those. It could be less than that on time, but it's once you have the relationship with the senior, it tends that it takes a little bit longer. So just for that copay that I mentioned, So what state was that in? And I'd like to check, make sure I follow up on that. She's typing that, so thank you. Very good. So start putting any questions in if you have for this whole entire webinar series, the webinar today. That's the amount in California, she said. So I'll check just against another state and get back to you on that. And I'll actually work on getting that into the post with Caleb, so we don't have until next week to have to wait on that. I'm making a note right here. And then I'm going to, if there's no other questions at the moment, I'm going to talk briefly about the myths that we saw. Most people saw in the field this last 5 years. Most people felt that the whole purpose of the program was to deny access, to literally deny access. And I don't see any evidence of that. I think that there is certainly some electives that may not be covered, but that doesn't mean they're denied the service. But that's not part of the quality payment program. And it's certainly demonstrated in the program that Medicare wants to pay for all the prevention and ambulatory services they can to prevent the disease state from coming to the point that it turns into a very long-term expensive stay for the patient. One of the things we also heard in the field was that engaging in the alternative payment models and transformation in particular were financially harmful to rural hospitals' financial bottom line. And working in an ACO environment, I was able to see a cohort of about 6 rural hospitals across the country that were participating in an ACO that did very well in their quality scores and were very diligent in their population health deployment. And what happened was, for the most part, they did not see any lowering of inpatient stays in numbers or costs. They actually saw an overall increase of 3% across the system and about 17% in the practice. So you had some reduction of inpatient admissions and certainly some reduction of ER visits, but the inpatient admissions were the preventable ones, like pneumonia. And then finally, they thought that a lot of doctors were very concerned that if they were doing population health, that the nurses would take care of the healthy patients and they would be only seeing the people who were chronically ill. And the model I just shared with you was really to actually extend the care to the nurses, and not the care, but the care plan to the nurses and then to the patient, so that it extends the doctor's care, but that doctor still has the oversight of the patient. It also allows the patient to be connected to the practice regardless of whether or not they are ill or not. So it builds a solid base of where the primary care is given in this day and time, where we're going to see a lot of opportunities for well patients to be enticed to go elsewhere. And then this is what you guys have been asking for. I'm going to make sure to skip a slide there. Yeah, this is what you've been asking for. So I was hoping for you to find a practice that would be able to dialogue with you in your value-based payments. And maybe even if you have gone out and talked to them and they did not do value-based payments, let's rephrase this now and say let's just find 5 that you can talk to. If they are doing value-based payments, those are who I would want to continue a conversation with for you to learn more about what their questions they're going to ask. But all I would ask you to ask those practices, or you can go to the call whoever's going to give the information in regard to the activity in the primary care setting. So what you want to know is how many Medicare beneficiaries or patients that each practice has, and then how many annual wellness visits were performed. And we're going to look for a percentage. And it'll be real interesting if each of you can find out that particular question. So moving forward, it will be a question that we'll try to ask in each one of the weeks moving forward. Any questions? I hear someone on the line.
Yeah, I have a question. This is Catherine. For some reason, I'm not able to type, so I apologize. What is the, I'm sorry I missed the boat. What is the original question? Like, what do we want to ask to find these people in the first place? Or find, is it who's doing value-based? What is the question we want to ask?
Yes, the question was, who do they participate in value-based payment programs? So that could be a Medicare Advantage plan that you actually get an extra payment for doing documentation on smoking cessation. Or it could be participation in CPC Plus or participation in an ACO.
Thank you.
You're welcome. Any other questions? So this week, even if you have not gone out and asked someone, or if you've asked someone and they do not have any value-based payments, ask 5 practices. Just find 5 practices of that are taking care of Medicare patients, how many Medicare beneficiaries they have on their rolls, not just met in the last year, because they may have some that haven't seen in a couple of years. So how many Medicare patients do they have? And then how many annual wellness visits do they perform in a year? And I see a question from Minnesota. Can we get all of the questions up front? We sure can. You guys, I know, have done some work already, so perhaps you have people that you would like to ask all at once, so I'm happy to do that. My hope was to help people start engaging in a regular conversation with a practice. So I will send you out a list for the rest of the week, for the rest of the series, hopefully, and then we can work on that as we move forward. And if you have questions, then at least you'll know or your practices will know what to expect moving forward. Any other questions? Well, I appreciate your participation today. I'm happy to have so many folks on and interested. Again, I'm trying to keep it a bit high level because we have lots of beginners in the value-based conversation. We will continue to build on this thought process in the next webinar next week. Caleb, do you have any closing statements? Oh, and I see someone talking.
Yeah, just that I saw Sherry type anything in. Yeah, nothing really to report on our end. Just a couple reminders. Please register for the reverse site visit. Registration is open. The room, what am I thinking of, Andy? The room discount or deadline to book your room is June 10th, so that's coming up. The 3rd episode of the COPD podcast series will be sent out later today, so you guys get advance notice of that, and that is going to be featuring Dr. Dan Doyle, a provider participating in the podcast series. So we're excited about that. Any other updates and things that I'm forgetting, Andy, while we have a few people on the line?
I think you got it all.
All right, that'll do it. And as usual, if you guys have any questions, please don't hesitate to reach out. My email address is csyme@ruralcenter.org, and Shannon's is up there on the website. And as always, the recording of this webinar and the slides will be available on the